2020. I am Dr. R.O. Duke-Majan, neurosurgeon, CEO and founder of Duke Spine Institute, and we are getting ready to do our third and final case for the day. If you're watching today, you're probably watching a live stream. All of our surgeries are live streamed from the Surgery Center of Viera and Duke Spine Institute. That way, you, the people watching, can ask questions and learn as we go along. Alrighty then. So our patient is here with back pain. Pain goes in the right leg. Our patient has a couple of disc herniations in the lower back. We'll be doing one today. And I'm going for the one that I think is causing the most pain. Our patient complains of back pain and leg pain in the right side. Very common with a herniated disc. Herniated disc is the cause of the pain. Herniated discs are probably the most common cause of back and leg pain. When a patient has back and leg pain, it's most likely a herniated disc. If they just have back pain by itself, it's usually due to arthritis in little joints in the back called the facet joints. Okay, we're going to get started, all right? Dr. Duke here. It looks like she's laying sideways. Is there a reason for that? This side looks higher. A little bit? No? Okay. I think we'll be okay. So, I'm going to give you some numbing medicine. You'll feel a little bit of burning in your back just for a few seconds, okay? It's not going to be bad, but it'll be uncomfortable. Now, if you feel any more discomfort throughout the surgery, you just need to say, ouch. When you say, ouch, that tells me I need to do something different to make you more comfortable, okay? What you're feeling back here is my hand. I've got to feel around because I got to find the right spot to go in and start your surgery. So I'm going to be pushing on your back a little bit, kind of feeling where your hips are, where your iliac crest is, etc. Okay, that's all normal. If there's a problem, I'll let you know, but I don't expect any problems at all. We good? You ready to go? All right, let's get started. A little stick and burn, remember, this is the most uncomfortable part probably. I apologize. Yeah, I know. If you want to get angry at the anesthesiologist. It's always his fault. If you feel good, you can always give me credit. All right. Sorry about that. You okay? Remember, lie still. Try not to move around. All right, just to verify, we're L45, right approach. Can you turn that monitor a little more so I can see it? It's a pretty dark image there. Yep. All right. So we have a normal 5-1, and we have a juicy 4-5 with a herniation. She has a 3-4 herniation as well. But we're not treating that today. Remember, if you feel any discomfort, just let me know, okay? Yeah, I'm just giving you some numbing medicine. Try not to move. Shot. All right, we need to be a little bit lower than where we are. Shot. Let's go lateral. So we're going to use a series of X-ray views. One view is through the front to back, the other view is from the side. You're going to see those views, and I use those views to navigate. Navigation just simply means using landmarks or body marks, in this case the spine, to get to a place. All right, the table's too far up. We need to drop it about 1/2 inch. Good. That's a long 1/2 inch. Shot. All right, not bad. I think we should come up just a little bit, quarter inch, good. And then I think we need to get a better view of the end plates at 4.5. Can you do that, Sean? Can you wag it until we get, I think we're close. We're very close, but just a little bit. Is that where you are right there? All right, so you can see we need to do some of this. I think your side needs to come up about 3 degrees at most. Shot? I think that's pretty darn good. That's about as good as we're going to get. Good enough for government work, that's for sure. All right. Let me know if you feel any discomfort, okay? Shot? Shot? So I'm on the facet joint. Where? Okay, just try not to move. You know, you've just got to say ouch and I'll take care of it for you, but I can't have you moving around, okay? Shot? You're doing great, by the way. Where do you feel that? Shot? All right. Shot? We're right near her facet. Shot? That's it there? Is that it? All right, yeah, she's moved, so. Numb them. Okay. Shot? Where do you feel that? Okay. Shot? Let's get an AP. You're doing really good, by the way. We need to adjust the wag. All right, back. Back to a lateral. You're pulsing, right? Uh-huh. All right, I think that's better. She's kind of settled back to where she was. You feel anything? Just Yep, that's just numbing medicine. Everything's okay. You're doing great. I'm just giving you a little more numbing medicine. Huh? Yeah. Right? Anything to take the pain away. Shot? You're doing great. Just hang in there. We're going to be able to put you to sleep real soon. But I need your help for this part right here. Shot? Shot? Wow. Shot? Shot? Where do you feel that? In your back, right? Try not to tighten up, Shot. Just relax, you're doing good. Promise, this is the worst part of the surgery. Shot. Yep. That's the old facet joint. Shot. You okay? Just about finished. We're going to be able to put you to sleep in just a minute, okay? Shot. All right, let me get an AP view. Shot, one more lateral, then AP. Better? Is that yes or no? All right, it's perfect. Go back to a lateral. Everything's going well. We need about 2 more minutes of your participation. Okay? Can you hear me all right? Shot. Try not to tighten up your back. I know it's hard, but I need you to... Have you given her any fentanyl? Huh?
I said I gave her some Versed.
But Versed's not a painkiller, right?
Correct.
Yeah, that's not helping me. She's moving, so that's making it really difficult for me to... No, it's not your fault, sweetheart. We're going to do a little bit on our side. Don't worry. Shot. I'm just about there, so... Shot. 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 Yeah. Shot. Shot. You okay? Where do you feel that? In the back. Where do you feel that? But not down your leg. The back, right? Okay, you're good. You don't need to give any. Yeah, we need it before that. Just in the future. All right. You better? I promise I'm not going to poke around anymore, okay? We're where we need to be. But I do need to test one more thing, okay? Are you okay? You want to catch your breath? Huh? All right. I'm just going to give you a minute anyway, okay? So here's what we're going to do. We're going to run a quick test, and then once that's done, we're going to put you to sleep, okay? I bet you're ready to go to sleep, aren't you? When you wake up, we'll be done. This disc will be fixed. And I think you're going to get some good relief. Just try to relax, okay? You doing all right? Just take a few deep breaths and relax. Now, how long have you had your back pain for? 2003. That's 17 years, right? What happened in 2003? Somebody hit you with a car? So someone pulled in front of you, you hit them? Oh, all 3 of you. So somebody pulled in front of the car in front of you. How fast were you going? 51 miles an hour. Did you ever file an insurance claim? What did they tell you? You didn't file an insurance claim? All right. So why did you decide to finally get your back fixed after 17 years? The pain, the numbness in your leg, and your drop foot. All right. Well, I'm hoping and praying that this surgery is going to work for you, okay? All right. We're going to have you count from 1 to 100 out loud, and when you wake up, we'll be done. But I have to do one more quick test. How bad is that on a scale of 1 to 10? A 9. Is that where you typically get your pain? Yes. All right, I promise I won't torture you anymore, okay? Sorry about that. Now you get to go to sleep, and when you wake up, we'll be done. Just lay still. 9 out of 10, concordant, L45. Shot. All right, so folks, I just did a discogram. She didn't know what I was going to do, and you saw her response. She almost jumped off the table. That was a lot of pain for her. So you can see the dye inside the disc, and it's kind of outlining the herniation. That herniation is going into the neuroforamen where the nerve is, and it's pushing on the nerve and irritating the nerve. Take this. Well, count out loud from 1 to 100, and if you make it to 100, I don't pay the anesthesiologist today. They're going to save me some money. Count quickly. He's a good guy. He deserves to be paid. If you don't like him, count fast. If you like him, count slow so he gets paid. Is she counting fast or slow? It's all good. All right, folks. This is a one-level right approach. I'm on the right side of the patient. This is the middle of the back, and this is the right side. Let me have the num-num medicine. I'm going to give her a little bit more local. It's on the long needle. Luis, don't make me yell at you this late in the day. Why do you think there's 2 holes in this dilator, Luis? Huh? I don't think that's going to fit, is it? Yeah. Why do you think there are 2 holes in here? Huh? Yeah. So I can give some numbing medicine. Right? Yeah. Shot. Isn't that amazing? Is she okay? She's fine on my end. I'm not having a problem. Shot? I'm very happy with her level of sedation. She may move a little bit. That's okay. I'd rather her be light than too deep. So we're about to make this more stimulating for her. So we're in the neuroforamen, folks. We're at the back of the disc. This is the disc that she has a tear. Look how fast the dye disappeared. That's not normal. Normally the dye sticks around inside the disc. But it came out quickly because there's a big tear. Shot. The bigger the tear, the faster the dye goes away. Let's see if I can kink 3 out of 3 of these wires. What do you think, Luis? Think I can do it? Nope, didn't do it this time. Shot. Okay, we're in. Like Flynn. Shot. Did that push the thing out? No. Shot. Shot. Some people ask me, Dr. Duke, is the stuff you're doing FDA approved? The answer is 100% yes. The FDA doesn't approve surgeries. It approves instruments, implants, medications. So pharmaceuticals and biologics, implants, instruments. All of the instruments we use are FDA approved. would never do anything that wasn't. I'm a rule follower, but also a trailblazer. Alrighty. Do we have any questions from our audience yet?
Not currently.
Not currently. All right, folks, get it together. I need some questions. I can't be the only one here talking. We don't want the patient talking, right? Okay, we're going to get started. We've placed the tubular retractor. We're heading inside, down the tube, aka the rabbit hole. And there is the disc. See the blue stain? That is the degenerated disc. I'm going to take some herniation fragments out, if Luis lets me. Bam. Huh? She's moving just a little bit too much. Yeah, all right. We're good. This is the inside of the herniation, deep. The deeper the herniation fragments, the less scarred they're going to be. It has everything to do with blood supply. And the further inside the disc you go, the less blood supply there is. So when you get into the nucleus pulposus, there's no blood supply at all unless it grows in from the periphery. In this case, there hasn't been a whole lot growing into this part of the disc, which is good. Makes it easier to remove the herniation fragments because they're not all scarred together. Luis, I'm not able to twist this. There we go. That's a little better. All right. All right, folks, ask some questions, or I'm going to start talking about something you may not want to hear about. Yes, that's a threat.
We have a question.
Yes.
One of our viewers wants to know, how long does it take you to diagnose a herniated disc?
That's a great question. How long? By the way, there's the tear right there. You see that blue? Right there? That's the annular tear. This is it right here. I'm zapping it away. How long does it take me to diagnose a herniated disc? So, I'd like to clarify the question because I can diagnose a herniated disc as soon as you give me an MRI scan. So if an MRI scan takes 45 minutes, I could diagnose it in 45 minutes. As a matter of fact, the instant I look at the MRI, I can see if there's a herniated disc. And if I have an opportunity to examine the patient, I can tell if the herniated disc is actually causing their symptoms. It depends on where they point, on their back or their neck. But the way we diagnose herniated disc is MRI. If the patient cannot have an MRI scan because of a pacemaker, defibrillator, shrapnel, some other reason, then we can do a CAT scan. And a CAT scan is not nearly as good as an MRI, but it's good enough most of the time that I can see a herniation. Then the other thing I could do is a discogram. That's where I put a needle in the disc and inject dye. Using a discogram, I could find a herniated disc too. So there's a variety of ways to diagnose a herniated disc. Probably the fastest way is a CAT scan, because these days CAT scans take like quite literally 5 minutes to do. But you're going to miss a lot of herniations with a CAT scan. And you may, the sensitivity is not that good. Okay? So the best test, MRI. 45 minutes. I could diagnose a herniated disc. Now, if you're asking me how long it will take me to diagnose whether a herniated disc is causing the patient's problem, that requires a physical exam and an MRI. Sometimes a nerve test. There's the tear, by the way, right there. The blue stuff's coming out. That's the interposed nucleus pulposus. This patient, I think, is going to do really well after the surgery. But remember, she has 2 herniated discs. We're only treating 1. So I don't expect her to get 100% pain relief like most of my patients do. I could get lucky, and she does, but I think we're going to need to treat her other disc in the future. Just some people are unable to do both at the time of the surgery for various reasons, usually financial, but that's okay. Getting one done is going to give her a lot of pain relief. All right. So I don't know if I answered the question well. I tried. I think I understand what the viewer is asking. Diagnosis of a herniated disc can only be made with diagnostic imaging. It's not a clinical diagnosis. It's not something your doctor can look at you and tell you by looking at you if you have a herniated disc. It's not possible to do that. You'd have to have x-ray vision. And I don't have x-ray vision, unfortunately. So we need tools, pictures, inside the body like an MRI. Yes.
Got a new question, Doc.
You got a question. All right, fire away.
What is a herniated disc and how do we get those or what causes it?
Okay, great question. So, what is a disc? A disc is a little cushion that your body has in between every single bone in your spine. Specifically, that's called the vertebral body. That's the name of that bone. And the disc is a little cushion. It looks like a mini hamburger right between the 2 bones, which would be like the bread of the hamburger bun. The disc has 2 parts. It's got this blue stuff right here, kind of a jellyish material in the middle. That's a shock absorber, and then it's got a tough capsule around it called the annulus fibrosus, or annulus for short. The annulus has to tear all the way through from inside to out in order to get a herniated disc. Once the annulus tears, then this blue jelly down here, it's not really blue and normally it's white, but it will shoot out through the tear under pressure from lifting or bending or twisting or jumping, any kind of activity involving your lower back. That's pressure on the disc of your bones pushing down from activities will push a piece of this jelly through the tear to the outside of the tear. Now that's called a herniation, that piece of jelly sticking out. Yeah, this is the painful part of her disc right here. We need about 5 minutes max and we'll be done. You're doing great. Everything's okay. And you can see that when she coughs, the disc moves. That's because she's doing something called a valsalva, where she's putting pressure on her abdomen to cough, and that pressure is transmitted through the spine to those discs, and you can see it moving. That's why when people have a herniated disc that hurts them, when they cough, it makes it worse because you can see the disc actually moving inside. Look at that. Pretty cool, huh? That's coughing. That's her coughing. So, the herniated disc occurs because of the annular tear. The annular tear must occur to have a herniated disc. That is absolute. There are some people out there trying to tell everyone that, oh, you can have a herniated disc when you have a fracture off your bone. No, that's not how it works. It works by way of getting a tear through and through from inside to out, and the jelly squeezes out, and that's the stuff you're seeing right here. That's why I stain it blue, because by staining it blue I can see it. I know what I have to take out. It helps me do the surgery. This is the tear. Literally, the tear is right through here. Bam. And the blue stuff is squeezing out through the tear. So I'm debriding the annular tear. This is a surgery that's only done by Duke Spine Institute. It's the only place in the world. Of course, there are other surgeons watching my videos and learning from me through my lectures, at meetings. When I talk about this surgery, I've taught other surgeons, and they're learning my technique, so they're going to start doing what I do. And if they do, they're going to be able to help patients overcome back pain and neck pain and arm pain and leg pain. This annular tear debridement is the most important part of my surgery. But it's the only surgery in the world that does this. There's no other surgery. We were the very first ones to publish this. I was the very first surgeon in the world to publish a debridement of the annular tear. And this is what takes the back pain away right here. Okay? Same thing in the neck. If you have a herniated disc in your neck and you've got neck pain, we can take that pain away by repairing the tear. What's the chance that it's going to come back again after my surgery? 1%. That's 1 in every 100 patients will re-injure their disc. And they'll get another herniation. Okay? But almost every single patient I've ever treated that had a re-herniation, they all tell me what they did wrong, and I know that that's what caused it. I've had a couple of patients where they don't know what they did wrong. One is a lady from Canada, and another one is another patient I have, and they're the only two that can't tell me what they did wrong. But everybody else that has a re-herniation lifted something too soon, too heavy, they felt a pop in their back. I had one patient who was a landscaper, and he was feeling so good the day after his back surgery that he went out and took a job and was unloading mulch bags out of his truck. He was lifting them and throwing them on the ground with twisting. The next day, right after surgery, and he felt a pump in his back. Of course, he came back and he re-herniated his disc. You see, you've got to give this time to heal before you do stuff. As long as you let it heal, it won't come back. All right, 2 minutes. This is the tear right there. How nice and white it is. Yep. Oh, I love it. I think she's going to do really good. This is the back of the disc right here, the epidural space up there. This is the last part of the tear. It's all calcified and scarred. Just about done. 1 minute. Right here is the herniation. You know, I chose neurosurgery because I love the nervous system and all the problems that we can fix and help people with. I never wanted to be bored in my career. That was the one thing I was very afraid of, is just getting bored with what I did. Everyone told me you should be a plastic surgeon. You can make a lot of money. It's an easy job. I don't know if that's true or not. I don't think it is, but that's what everybody seems to believe. But I just couldn't be doing breast augmentation my whole career. I would be bored too much. I like challenges, so curing back pain and neck pain is it's a good challenge. It's I think a noteworthy challenge. I can feel good about having accomplished this in my lifetime. I don't think I could lay on my deathbed and think back and say I did 10,000 boob jobs and I achieved something great in life. I just don't see being able to convince myself of that. What do you think?
Well, I think you make the husband happy.
You make the husbands happy. So I made 10,000 husbands happy. That's funny, Luis. You know what? You're right. I'm going, guys. I'm going to go do plastic surgery. I'll see y'all later. No, I'd rather cure pain. I would rather cure pain. I'd rather cure something nobody else can really cure. Just done. That looks good. A little bit of fat coming out of the epidural space. No big deal. Standby laser. We leave that alone. We're done, folks. Hope you enjoyed it. Scope off.
Thank you, Crystal.
Any questions from the audience?
No, sir.
Oh my, just that's it, huh? All right. Well, I hope you enjoy this endoscopic spine surgery live broadcast from Duke Spine Institute here in Melbourne, Florida. As a matter of fact, I used to joke with people. I said, this Melbourne, Florida, this Melbourne doesn't have great white sharks. But we do. Did you read the newspaper today? They saw, I think it was a 12-foot great white shark off the coast of the Space Coast. It's got a tracking beacon. It showed up yesterday. Yeah. Take second thoughts about going swimming off the beach, right? Let's see what we got. All right. So Luis is going to apply pressure, but here's the incision. You all see this?
Yes, sir.
All right, right there. 7 millimeters. Go ahead, Luis.
Yes, sir.
Good job, everybody, today. Thank you so much. I'll come and answer any questions the audience has. Type up your question right now, and we'll read it over the internet, and I'll try to answer it. But great work today, everyone. Thank you. Well, by the way, the first patient was a 3-level. She left an hour after surgery. 100% of her pain is gone. Her video is posted. Our second patient left. Her pain is completely gone in her back and leg. She's happy, and hopefully we'll be just as fortunate with this one as well. Drop foot usually takes 6 months to a year to recover if they come in with a drop foot. I'm going to call our EBL 3 mil. No complications. This was another right. L45, right? All right, everyone. Thanks again. I appreciate it. I'll be over there to answer questions. Type fast.
All right, folks, we have our first question. I have Dr. Duke here. We'll be taking questions, so if you have any questions, please type them in. We have our first question here from Ernie from Facebook. I have ankylosing spinalitis with major damage to neck, thoracic, and lumbar, several herniated discs. Neck has 4 bones pressing on spinal cord. Most pain in neck, natural fusion occurring. What would you do, sir?
Ernie, I'm very sorry to hear that. This is Dr. Duke Majan. Yeah, ankylosing spondylitis, folks, is a horrible condition that some people get. It's inflammatory, and their spine is constantly in inflammation, the whole spine. It's horribly painful, and, honestly, Ernie, I need to see your films. I need to see, why are you having pain? If your pain is just coming from the bones and joints fusing together, there's not much I can do to help you. I could, to be honest with you, I could cut those joints out surgically and fuse them for you. That would at least end the pain for you instead of letting it burn out over years. It's not a bad idea. I would really need to see an MRI of your spine. I would really need to see flexion extension x-rays and a CAT scan. So CT scan, cervical spine, x-ray, cervical spine with flexion extension views, and an MRI scan. Then I would really like to do a interview with you over Skype and look at where your pain is. If your pain is something that can be fixed with a needle procedure called a rhizotomy, we do that first. On the other hand, if you did have herniated discs that were causing your pain, I could fix those with the laser surgery. But if your pain is just coming from inflammation of those facet joints as they fuse, I would recommend a rhizotomy first. That's the first thing I said. So we can help you, I think, but it's really, unfortunately, this condition is a tough one. It's really a tough one. What the spine does, folks, is it fuses itself, but it doesn't happen overnight. It happens over really years. And so the patients with this problem live with suffering with pain for years. And it's not something that they can get rid of with pain medication very easily. So, yeah, it's a bad condition, but I think we can help you, Ernie. I just need pictures sent in. I review them for free. And a Skype call, which we do for free also. So you don't have to come here for your first visit. Duke Spine Institute offers free review of your films and free consultation with some recommendations over the internet through Skype. That way I can do a quick physical exam, limited of course by the fact that we're on the phone and a video conference. I can't touch you, but you can at least see where your pain is and what precipitates it, what kind of movement you've got left in your neck with rotation, extension. So there's a lot of things I can accomplish just by doing a quick face-to-face physical exam over the internet. And by the way, the free MRI review and free consultation is free and available to, how many people are living on the earth right now? 8 billion. So we offer this to 8 billion people for free. That's anybody out there that wants to talk to me or Ann Caldwell, our director of nursing. She's the best. Whenever I have something I don't know what to do, I just give her a call. And then if she can't answer it, we call Ghostbusters. But no, seriously, we do offer free consultations to try to help people out, just like Ernie, where they're not sure what to do. They want the latest and best. We're willing to offer that at no charge. Thanks, Ernie, for writing in. Good luck, and hopefully I'll be able to help you if you send your stuff in. That was our last question. What can I say about the surgery? I thought this one of all three today went the easiest for me. This patient didn't have a lot of bone spurs or, joints that were really big and arthritic. This patient had, honestly, really mostly just a herniated disc and none of the scoliosis or listhesis or facet arthropathy that we saw with the other two. So her case went pretty quick. I think she's going to do really well. The only thing, like I said earlier, was, she has 2 herniations that need to be done, but we're only doing one for financial reasons. It's limited. and that's understandable. But you know what? Getting one disc fixed out of two could give you 50, 60, maybe even 70 or 80% relief. And for a lot of people, 80% relief is huge. It makes a big, big difference in their life and their quality of life. So I do what my patients want me to do in terms of what's reasonable to do. I don't do anything they want me to do. I do what I think is safe and effective for them if they want me to do it. So this patient wanted to move forward with one disc, and I thought that was very reasonable. Besides, she has a drop foot, she's got weakness, so something had to be done surgically to unpinch that nerve. She should be out of here in about 30 minutes, and then it's going to take her 6 months to a year to recover her strength in her foot. Aside from that, I think today was a bit of a challenging day, just getting in and getting the surgery done because of patient's anatomy and their collapsed discs and spinal rotation and all kinds of stuff. But we got through it, and I think the first two patients had 100% pain relief. They were on no painkillers whatsoever when they left, and they had no pain. All right, all of it gone with the Duke laser disc repair. Have a blessed evening. Remember to download the Duke Spine Institute app. It's free. Load it up and check it out. And if you want to talk to me, I do it for free, no charge, no obligation, just to help people out around the world. Feel free to contact our office and schedule a 10-minute face-to-face with Lauren and her team. Thanks.